Nope, that works. All right. Can you hear me okay, Elizabeth?
Yes, I can hear you great. Thank you.
All right. So I will start with an OPAT case to begin with. So our patient is a 30-year-old, 30-something-year-old male who was in a side-by-side accident about a month prior to ID being consulted. And that resulted in fractures of multiple digits, as well as loss of his third finger, and then a degloving injury of his hand as well. So he was taken to the OR, has had IND of his fractured fingers as well as his hand, and then taken back for re-exploration of his left hand wounds with a closed reduction of his left index finger. So underwent some pinnings, INDs to bone, and then kind of cleaned up the amputation of his third finger. And he was discharged with 10 days of Keflex. So a couple weeks later, he presented for his surgical follow-up and reported he was having intermittent fevers. And on exam, he had signs of infection. So it was red, there was pustular drainage. It looked like the distal part of his second finger had full thickness necrosis. At that point, they knew they were going to have to take him back to the OR, and we're just trying to get the timing. So empirically just started him on doxycycline and ciprofloxacin. And then 2 weeks later, so it had been about a month from his initial surgery, he was admitted and underwent another IND of his fourth and fifth digit that had obvious dry gangrene, and then amputation of part of his index finger. He also had IND of his dorsal and palmar wounds, which went to bone, and then had graft placed with K-wires, which is what you see there. Had OR cultures sent from his hand, and was empirically started at this point on IV vancomycin, cefepime, and PO flagyl, and ID was consulted. When the ID physician saw him in-house, he said he was doing okay, tolerating the antibiotics, but was having some pretty significant nausea and occasional vomiting with the flagyl. So didn't really want to continue that agent if possible. By about day 1 post-op, his OR cultures started coming back. He grew Clostridium species from his anaerobic culture, Enterococcus faecalis, which was ampicillin sensitive, and then also grew a Chromobacter and a Pseudomonas species that couldn't be, sensitivities couldn't be done here, so it had to be sent out to our reference lab. Aside from this accident, he really had no past medical history, no surgical history or allergies. He had worked construction, and at baseline was able to perform all his ADLs. So the questions we have kind of at this point, so we have some OR cultures with some sensitivities, but not all of them. Is the patient a candidate for IV antibiotics, or could we maybe go the oral route? And then what's the duration of our treatment for this patient moving forward? Any comments or questions so far?
And I can always pull the case back up if anybody needs to look at it again. But feel free to unmute, chat it in.
So I would kind of sum him up as a polymicrobial and complex skin soft tissue infection with probable bone involvement, with some amputation, and then also had the INDs down to his bone. And the organisms that were growing so far it's hard to say exactly where those came in. He has the Pseudomonas species. He has a Chromobacter species. That's often a water bug and found in soil. So I'm wondering if that was there from the initial accident, and then some anaerobes, and had been on some antibiotics before all of this. So one of the big questions we first ask from an OPAT standpoint is, can the patient do IV antibiotics, and where are they going home? So this patient's plan was just to be discharged home, and his girlfriend was going to help with IV antibiotics if necessary. Because he had had CIFR previously, we were a bit hesitant to start with a PO regimen. So the consulting ID doc had said, let's try Zosyn first. And we put him on Zosyn 18 grams continuous infusion in the OPAT setting for a planned 4 to 6 weeks for his infection. Questions so far? If you don't mind pulling the case back up and scrolling down some more. So like I said, we put him on Zosyn. My hope was that when his sensitivities came back, he might be an oral candidate. Unfortunately, yeah, his Pseudomonas and his Chromobacter were both resistant to fluoroquinolone. So we were a little bit stuck. Luckily, though, Zosyn seemed to be a good drug of choice. You can continue to scroll down. The next kind of OPAT issue we encountered. So here are his lab results. I know it's kind of confusing. So my week 1 is like on the other, yeah, like if you're reading backwards, I guess. His initial labs were all pretty normal. I mean, he was a healthy guy at baseline, but as he was getting into week 3, week 4 of his antibiotics, you can see his white blood cell count was starting to kind of slowly trend down, and his ANC, which was 2,000 at that week 3, was then 1,500 at that week 4. So he was starting to have some neutropenia. Otherwise, his labs really looked good. He did go to the his surgery follow-up right when he started getting neutropenic. And they had said that on exam things looked good, but there was still some green drainage, especially when they removed the K wires of his Integra graft. They were still really hopeful that he wouldn't have to go back to the OR for more debridement, but had even commented they felt like he needed antibiotics for at least a few more weeks. So now we're kind of at a point where we have a patient with neutropenia and a need of IV antibiotics. And it's kind of, where do we go from here? So do we just push him through? Do we switch his agent? And if we do switch his agent, what can we change him to? This is where, well, actually, I'm always talking to my IV pharmacy friends, but this is definitely where I kind of call them. When I handle neutropenia on IV antibiotics, I kind of look at a couple of things. So one is, do they have any other lab abnormalities? Are they showing any kind of liver enzyme elevation, eosinophilia? Those I always take a little bit more seriously versus someone with just isolated neutropenia like him. I make sure that they're not having any fevers and chills, but especially if we're looking at multiple weeks of antibiotics kind of moving forward, continuing the agent will just continue to put this pressure to cause neutropenia. So I knew that we were going to have to switch. Based on his sensitivities and things, what I've found helpful is for these reactions is trying to find an antibiotic that is a different flavor. And I'll often use this beta-lactam cross-reactivity table, which you can find on Google too. what we ended up doing was adjusting him to meropenem to finish out his full 6 weeks, and he had resolution of his neutropenia with agent adjustment. Any questions or comments at this point?
Did have a chat come in. I'm gonna probably butcher this. Jacob,
So,
why not cefepime?
yeah, that's a good question. So there were a couple reasons we didn't do cefepime that I kind of failed to mention when we first started. So when he was in the hospital on bank cefepime and Flagyl, there was some signs that his ANC was starting to trend down at that point. The other thing is he didn't tolerate the Flagyl previously. Now I could have given that IV, but that is just one more IV infusion that the patient would have to do. And some patients will still have that nausea and upset stomach that you get with oral Flagyl, even on IV. So that was one of the biggest reasons we went to meropenem, was to get our anaerobic coverage as well as our previous organisms. Follow-up comment to that, Jacob? Oh, and there was some resistance to cefepime. That's the big reason. The Chromobacter was resistant. Yeah. So that's a good question too. If he, so like, let's say there wasn't resistance to cefepime, I probably would have called the anaerobic coverage as well and maybe switched him to cefepime. Cepepime's really nice in the outpatient setting too as an IV antibiotic. It's usually delivered as a push, so it's really quick to give. And I would have just felt like those anaerobes were probably dead by now, or at least dead in the OR when they were exposed to air. Thanks, Jacob.
Thank you so much, Jacob. Anybody else have any comments or questions?
I have a question. So this is a great table, the beta-lactam cross-reactivity chart.
Yeah.
It was interesting how you kind of used it. When I thought to look at it, I'm thinking of allergies like rash or anaphylaxis, but
Good
to
point.
also
Yeah.
look at the differences using this table in cases like neutropenia or leukopenia. So
yeah, I can't say that
Great.
that's you're absolutely
sense.
right.
No.
Like why? What, like that's
No,
a justified reason. That's just kind of what we've done.
yeah, no, I like that. You taught
And
me
it's
to-
worked.
and,
Yeah, yeah.
Another tool to use. So I'm just saying things.
Yeah, no, neutropenic, antibiotic induced neutropenia is tough because there's not a lot of literature or a lot of guidance for it, especially in patients like this where it was isolated neutropenia without any other symptoms. That makes me try some more unusual things a little bit more often, just because this guy is young, he's stable. I know how to get a hold of him really easily. His neutrophil count wasn't, like 100. So we had a little wiggle room. Yeah. Thanks, Joy. Yeah.
Thank you so much. Do you want me to scroll down a little bit more, Jess?
That was pretty much all I had, unless there were other questions or things.
All right. Thank you so much for that case. Really appreciate your time and energy you put into that. All right, Joy, are you ready for yours now?
Sure, thank you.
Of course.
Scroll down if you don't mind to the history of present illness, just to start there. Thank you. And then we'll go back up. This patient is a 46-year-old male, and he was admitted to our hospital here at Ruby from September 28th to October 2nd with MRSA bacteremia. And at that time, he also had a urine culture on September 25th that grew MRSA with a high colony count greater than 100,000 colonies per CFU per milliliters. His blood cultures grew MRSA from September 26th to September 28th with clearance of bacteremia achieved relatively quickly on September 30th. He had a transthoracic echocardiogram as well as a transesophageal echocardiogram that didn't show any evidence of infective endocarditis. So his MRSA bacteremia was attributed to entry through a chronic diabetic right first toe ulcer or callus. And I'm just going to pause here for a second. There is more to the case, but just to get an idea of who would feel comfortable transitioning to an oral regimen at this point and say finishing his course with oral antibiotics with close monitoring. Anybody? Not yet. Okay, fair. So he was actually enrolled in the COpAT trial that we're doing here across 5 WVCTSI hospitals and randomized to oral antimicrobial therapy. He was discharged on linezolid and completed nearly the entire 4 weeks of antimicrobial therapy dated from bacteremia with linezolid with the end date of October 27th. And he was stopped at that time because he was doing well clinically at follow-up in ID clinic, and his CRP had normalized very quickly, really, within about a week, and then it remained normal at the end of treatment. It was 1.6. And by the way, he tolerated linezolid very well. So during subsequent follow-up in ID clinic, 6 weeks after hospital discharge, so after he had been off antimicrobial therapy for about 3 weeks, he started having dysuria, and he had said that he actually had dysuria prior to his MRSA bacteremia when he was admitted in September. His urine culture on November 11th that we had repeated also grew MRSA greater than 100,000 colonies. And then based on this information, he was diagnosed with an MRSA prostatitis. So if you don't mind just going back up to the proposed antimicrobial therapy. And these are just some ideas, and then this is open to discussion at the end. So which antimicrobial therapy and why? So the patient was initially treated with linezolid, as I mentioned, when he was admitted from the MRSA bacteremia, thought to be from kind of skin and soft tissue entry with linezolid. And when he was diagnosed with the MRSA prostatitis, we opted to treat him with Bactrim, just a regular dose, 1 tab twice a day, Bactrim DS. And that was because both have good MRSA coverage with high bioavailability. So linezolid 100%, Bactrim 900%. But with the MRSA prostatitis, we anticipated and planned for a prolonged duration and thought Bactrim may be a good option with monitoring through our COpAT program. So if you just continue scrolling down, please. Hit some highlights of his case. So past medical and surgical history, the main thing here is an uncontrolled diabetes. So he had a hemoglobin A1C of nearly 13 and had this chronic diabetic right first toe ulcer or callus that he had been following with wound care for. Increased BMI, and then medications. Pertinent ones here, I think, are medications for his diabetes, as well as he was on a lisinopril, and then also atorvastatin. And no allergies to antimicrobials. And then here's his physical exam. So actually, both when we met him in the hospital and then in ID clinic, he was well appearing, lungs clear, heart regular. And this is a picture of his right first toe callus. And as you can see, there's not really any evidence of infection. And maybe there was a little bit more of kind of debris when he was admitted, but still the foot didn't look grossly infected. So his labs here are listed. His maximum CRP was when he was admitted with MRSA bacteremia on November 28th. It was almost between 35 and 40. And then at the time of evaluation, November 15th in ID clinic, his CRP had normalized and then increased back up to around 30 again. And you can see here, we of course checked ID labs, CBC looks okay, and then his renal function is normal. And then kind of going through the imaging, you know, not too pertinent that the x-ray that he had when he was admitted showed some maybe chronic tiny erosions, but nothing too significant on his right foot. Did have CT abdomen and pelvis that just commented the prostate was mildly prominent when he had the MRSA bacteremia. Nothing further. Had an MRI of the right foot that showed no evidence of osteomyelitis. And then, you know, of course, the cardiac imaging showed no evidence of endocarditis that I already went through. They also imaged his spine just to look for, I think, a source that maybe had a couple complaints of back pain at some point that was negative. So, of course, at this point, he has no vascular access. He's coming back to clinic, been off antimicrobial therapy. So some questions about this case would be, how would you summarize it? And then how would you treat this patient? You know, especially the second go round when he is diagnosed with the MRSA prostatitis, and how long? And then would you be concerned, or what are possible oral antimicrobial toxicities? And I can give a follow-up on his case after a little bit of discussion.
Yeah, please feel free to unmute. So the first question again, how would you summarize this case? Nobody come across a case that's similar that can, you know, add some input here?
I guess I would have summarized him as a complicated MRSA bacteremia, likely from a urinary source, but I would have only kind of felt comfortable making that statement after, like, knowing that he had that urine culture then return positive again for the MRSA. I think most likely when we think of MRSA bacteremia in patients like this, it is from a skin soft tissue source. So looking and pinpointing the toe was definitely where my mind would have gone. And then expecting that the urine culture, when it first was positive for MRSA, was more from like blood to urine. So instead of the opposite direction, which may have actually been what was going on. I don't know if that makes sense.
Thank you for that, Jess. Does anybody agree or disagree? That's fine too. It's a safe space.
We were thinking too, when he presented, you know, he had the callus entry through the skin and the setting of uncontrolled diabetes with a positive urine culture. Initially thought maybe descending from the MRSA bacteremia. He came back to clinic kind of with dysuria that he had disclosed experiencing early on.
So when I had seen him in clinic the second time around at his 6-week visit, during that visit he had said these symptoms of urinary discomfort are exactly like they were when he had the first. So that's when it started to click that maybe it was the other way around.
Sure, yes. Was the diagnosis of the prostatitis, was that just based on that prostatomegaly that was seen on CT imaging?
Correct. And just, it was a clinical diagnosis, didn't do a rectal exam.
Based on
Cultures and
his presentation and the urine cultures being positive, and then the same organism being isolated in the urine, kind of the CRP elevating infection coming back after stopping when we treated for a short duration the first go around. So we kind of summarized him as initially an MRSA bacteremia that at that time was thought to be from a right toe callus or infection. Ended up being treated with 4 weeks of oral and nasal, and had clinical resolution. The foot looked fine and really did all along, but with resolution of inflammatory markers, and represented with dysuria and was diagnosed with MRSA prostatitis. And our thought is that he had MRSA prostatitis from the beginning, and we just didn't treat for a longer duration because we assumed it was a skin soft tissue source.
Thank you very much. There are a couple other questions. Did you want to ask those other questions too? Like, how would they treat it?
We're in this, got the 4 weeks of linazolid the first time. Now our goal is to treat for a longer duration. What would be a proposed regimen? Anybody give a regimen that we're gonna resume antimicrobial therapy? What would we start them on?
Bactrim.
Very good. So we did start Bactrim. Again, 1 tab double strand twice a day with our planned 3-month duration. Good choice. And we had a plan for laboratory monitoring in place through our COpAT program. The title of this topic is but major antimicrobial toxicities, right? So any guesses as to what happened next or what his labs may have showed?
Spectrum, I mean, the like classic question you see on all your tests is like Steven Johnson syndrome with Bactrim or rash with Bactrim. That's a good one I see up there. Like hyperkalemia. I've had that with a couple patients that I've had to use Bactrim who were on an ACE inhibitor and are sometimes I'll see if they can just like hold it and try and stay calm so that their blood pressure isn't too high. But other good points, I think we're up there. And then they can also get cytopenias with Bactrim too. So yeah.
All really good points. So in his particular case, we got labs back after approximately 1 month of therapy, and his creatinine has increased to 1.5 and potassium was 6.4. So definitely hyperkalemia, had been continued on his lisinopril with the Bactrim after the first month. So he was transitioned from Bactrim back to linazolid for another month, which he tolerated very well. His acute kidney injury hyperkalemia quickly resolved. The CRP did normalize, by the way, even after the first month of Bactrim again. And then through the last month, we planned to transition him and did transition him to doxycycline, even though he had continued tolerating the linazolid for the last month of therapy. So he tolerated both linazolid and doxycycline very well. He was seen last month at the end of treatment and asymptomatic with CRP remaining normal, 1.9 or 2. And then we kind of went through the last case a little bit, or the last question, I think I said, would you be concerned about possible oral antimicrobial toxicities? Planning medication, like for example, linazolid for a period of time, Bactrim for a period of time. And most patients we've put on oral antibiotics, we've found do quite well. We've had a few in our personal experience issues with linazolid. From a COpAT program standpoint, this is just out of our experience here. We've seen Bactrim cause some hyperkalemia, acute kidney injury, and toxicities like that. But I think good decision to put the patient on the regimen, and that's why we have programs in place like OPAT and COpAT to be able to monitor these patients and make adjustments when needed. Any other discussion?
One of the aspects of his MRSA I had noticed was he had what I would describe as that community-acquired strain of MRSA, which doesn't have multi-drug resistance. And I think many of us will remember that many years ago when that strain first started, initially as pneumonia in children, and then the skin soft tissue problems. There was a lot of patients with community-acquired MRSA strains that were presenting with infections that are not traditionally associated with Staph aureus. So, for example, septic pelvic thrombophlebitis was one infection I remember seeing, and it did cross my mind as to whether that strain was more prone to causing prostatitis than, say, other strains of Staph aureus, like the hospital-acquired strain.
In the beginning, right, based on when.
All right, thank you very much. Any other questions or comments before we move into the presentation? Here with the echo pause. All right, great. Thank you so much, Joy and Jess. Really appreciate the cases and your comments, and thank you for the questions in the chat and responses as well. All right, David, are you ready to present your case? Did you want me to share the slides, or did you want to do so yourself?
Yeah, I can share them from here. Just let me know if it works. Okay, are you seeing the slides?
Not currently, no. I give you capability to share your screen.
Um, okay, how about now?
Perfect.
All right. Okay. So as what has been mentioned, today we are primarily discussing some antimicrobial toxicities and the monitoring that is recommended for these. For some learning objectives for today, it's not letting me advance the slides. Let's see, there we go. Okay, so first is to identify the antimicrobials that are commonly associated with neutropenia. Second, monitor and manage antimicrobial-induced neutropenia effectively. And then we will shift gears a little bit and talk a bit about daptomycin-induced eosinophilic pneumonia and the signs and symptoms involved. So first, neutropenia. So neutropenia is a decrease in neutrophils. These are the primary white blood cell and a primary component of the host defense system. A decrease in neutrophils results in an increased risk for both severe and frequent infections. Neutropenia has been described in the literature as being most commonly associated with beta-lactams and vancomycin when we are talking about antimicrobial induced neutropenia. There are varying degrees of severity for neutropenia, with an ANC of 1,000 to 1,500, typically categorized as mild, 500 to 1,000 as moderate, and less than 500 considered severe. Neutropenia has been described in the literature with virtually all beta-lactams, and it's been associated with durations of therapy that exceed 2 weeks. Among those patients receiving greater than 2 weeks of therapy, the estimates in the literature vary, but tend to be somewhere around 10%. Some beta-lactam agents are considered to be at higher risk for causing neutropenia. They've been reported more often in the literature to have this association. And some of those agents include ceftaroline, piperacillin tazobactam, ceftriaxone, nafcillin, oxacillin, and penicillin G. Now, the exact mechanism behind beta-lactam-induced neutropenia remains a bit unclear. Some of the leading theories out there in the literature is that this involves some type of direct toxic effect or an immunologic reaction that involves hypersensitivity, or that this is some combination of those two. Several studies in recent years have suggested that when a patient develops neutropenia while receiving a specific beta-lactam, the patient can be directly transitioned to another agent that has a distinct R1 side chain. So I have included this here to highlight the structures of penicillins, cephalosporins, and carbapenems in general. And highlighted here in blue is where the R1 side chain is located on each. The hypothesis is that the R1 side chain plays a role in the hypersensitivity reaction that can occur in response to administration of a beta-lactam, and that can include development of neutropenia. Jess shared this table earlier, and there are a number of similar resources that are available in the literature that include tables that help with being able to compare the R1 side chain of various beta-lactams. This particular table can be found on the Enterprise Antimicrobial Stewardship site that's accessible via the WVU Medicine Connect page. And it can be a quite helpful of a resource in order to determine what options you might have when a patient develops neutropenia to a specific agent. So we do in clinical practice see neutropenia from beta-lactams fairly often. Now, while neutropenia has historically primarily been described with beta-lactams, recent data suggests that vancomycin may actually be even more highly associated with neutropenia than beta-lactams in clinical practice. As with beta-lactams, neutropenia with vancomycin is primarily seen with durations of therapy longer than 2 weeks. A recent retrospective cohort study in 2023 by Lamb and colleagues evaluated over 2,500 OPAT courses, and they determined that vancomycin had the highest incidence of neutropenia of all agents. The incidence of vancomycin-induced neutropenia does vary in the literature. I've included 2 studies in this table here. So the first was by Pai and colleagues in 2006. They looked at 114 courses of vancomycin and observed a neutropenia rate of 12.2%. And the median duration to onset was 26 days. And then there was the more recent study that I referenced before by Lamb and colleagues. This was a larger study that looked at, of those 2,500 courses, 541 patients received vancomycin, and they saw a neutropenia rate of 5.6%. Notably, the duration to onset of neutropenia was very similar between these two. So kind of highlighting that although we typically don't see it before 2 weeks, maybe it's a bit more common to see it kind of at that 3 to 4 week range. Now moving into how do we manage this? So the primary management really involves timely discontinuation of the offending agent, whether that be a beta-lactam or whether it be vancomycin or something else. The use of granulocyte colony stimulating factor has been advocated for by some, particularly for patients that have a very poor prognosis. While this has been described in the literature some, the data supporting the benefits of this practice still remain a bit limited. So that's not something that is routinely done for patients. But there might be select cases where you could consider doing that.
Do you mind if I make a comment on your last couple of slides?
Yeah.
So going back to that slide about the vancomycin, I know that recently with that study out of Lamb that focused on OPAT patients, we've used that as an excuse to get patients off vanc. I know the most recent patient I had was a CNS infection on ceftriaxone and vanc, and the ID physician who was seeing the patient in clinic was really hesitant for me just to switch the vanc to linezolid, but it worked. So it was another patient that had asymptomatic neutropenia, needed several more weeks of antibiotic therapy, had that steady kind of decline of their ANC, and we stopped the bank and switched them, and their neutrophil count popped back up. I've had a lot of success with changing bank in these patients that are on like a multi-antibiotic regimen, and blaming the bank as a reason to get them off of it, which is always my goal. And then the GCSF, I think we've been able to get one patient GCSF for a similar situation where they had a lot of allergies, needed a really long course. I've had trouble getting that approved, though, 99% of the time. So for since it is kind of an experimental use, but thanks, Dave.
Sure. Yeah, thanks for adding those comments. So now I'll shift gears a little bit over to talk about daptomycin-induced eosinophilic pneumonia, which we have seen a few cases of this recently. So daptomycin is typically a pretty well-tolerated agent, with significant tolerability benefits over agents that have a comparable spectrum of activity, such as vancomycin. However, it still does have a number of toxicities to be aware of. And the one that I wanted to highlight today is this eosinophilic pneumonia. So eosinophilic pneumonia can be caused by a number of different things, including a number of different medications, but daptomycin has been identified as the leading cause of medication-induced eosinophilic pneumonia in the literature. However, the incidence of this is still quite rare. Estimates range from 1.5 to 2% in the literature, but it's still something to be aware of because it can be a potentially severe adverse event. Just as with the antibiotic-induced neutropenia, the mechanism is not entirely understood, but some of the proposed mechanisms I have listed here. So the first includes T-cell lymphocyte activation leading to interleukin release, which leads to eosinophil production and migration to the lungs. The other has to do with daptomycin binding to pulmonary surfactant, which is hypothesized to lead to inflammation and cell damage. Or after that is kind of just some combination of those two mechanisms. So what does eosinophilic pneumonia? Symptoms that are described is that the patient will present with, shortness of breath or dyspnea, potentially a cough, fever. This will lead to the patient, oftentimes, it will prompt clinicians to obtain imaging for the patient, on which they might see either on chest X-ray or CT scan diffuse bilateral pulmonary infiltrates. Laboratory findings that you might see are elevated eosinophils on a BAL, so greater than 25%. You may also see peripheral eosinophilia, but I wanted to note that the literature describes that, neither one of these has to be present, nor is it present in all cases of eosinophilic pneumonia. So really, the symptoms and the imaging are pretty critical pieces here. But the eosinophils can assist us in that diagnosis. Risk factors have been described in the literature, and I've included some of these here. So a duration of therapy greater than 10 to 14 days when you start to have high total cumulative doses. So it was described as greater than 10 or equal to 10 grams. Older age, it's more commonly associated with male patients for unclear reasons. It's also more common to see in patients that have significant comorbidities. So with the Charlson Comorbidity Index score greater than or equal to 5. How do we manage eosinophilic pneumonia? Again, similar to neutropenia, it's primarily prompt discontinuation of the agent, as well as supportive care. Improvement is typically seen in these patients within 24 hours to 1 week of discontinuation. However, the literature does describe that in rare cases, chronic pneumonitis may result. And this may lead to the patient requiring a course or a long-term corticosteroid. And it should be noted that, re-challenging these patients is typically not recommended, as the literature has described recurrence upon re-challenge. Now, I wanted to highlight a recent case series that looked at 17 cases of daptomycin-induced eosinophilic pneumonia. So this was specifically in patients with a bone and joint infection that received greater than 2 weeks of daptomycin therapy. So in the study period, they evaluated over 1,000 patients that received daptomycin, and just 17 of them experienced eosinophilic pneumonia, so the incidence being 1.7%. Notably, when looking at patients who had an elevated eosinophil count on their BAL that was greater than 25%, just one patient was found to have that, to meet that criteria. However, a significantly greater number of patients did have peripheral eosinophilia, so greater than 5%, with 15 out of 17 patients meeting that criteria. When looking at imaging, the vast majority of patients did have a CT scan that was compatible with eosinophilic pneumonia. The good news here with this is that all 17 of these patients recovered rapidly upon discontinuation of daptomycin. So these authors, in their conclusion, they propose that the diagnosis for eosinophilic pneumonia be based primarily on symptoms, CT findings, and systemic eosinophilia, as these patients had, in this case series, had a very low incidence of having an elevated BAL eosinophilic count. So in summary, beta-lactams and vancomycin are both highly associated with neutropenia, and so they do require monitoring, particularly when you're going to send patients out on long durations of therapy. The primary management for antimicrobial-induced neutropenia is to discontinue the offending agent and either switch to a medication in a different class, or in the case of beta-lactams, you can consider switching to an agent with a distinct R1 side chain. Eosinophilic pneumonia is a rather rare complication of daptomycin therapy. However, we should be educating our patients about this possibility so they know what signs and symptoms to watch for. And we should also appropriately monitor these patients and reach out to them to also ask them if they're experiencing symptoms once we notice any issues in potential issues in labs. The primary management of daptomycin-induced eosinophilic pneumonia is to discontinue the agent. So that is all that I have today, but I'd be happy to answer any questions if anyone has any.
Thank you so much, David. Thank you. That was wonderful. I really appreciate that and your time. We did have a question come in. How long until you're comfortable reintroducing the offending agent, or do you place it as an allergy to not use again for neutropenia?
Yeah, I typically, if we're able to confirm that the patient developed neutropenia to that specific agent, I at least in my experience, I can't say that I've then gone on to trial that same agent again. Have others had different experience with that than I have?
That's a really good question, and I can't say that I found the perfect scenario. Some of the patients, especially who seem to develop asymptomatic kind of mild neutropenia, I always worry about adding it to their allergy list, mostly because of that sometimes will inadvertently eliminate a lot of antibiotics, and then they kind of go down the road of only getting certain types. Especially if it's asymptomatic, I tend not to. I always mention it to the patient and then just kind of hope that if they are reintroduced to an IV antibiotic, that they need the IV antibiotic to begin with, and that they'll be in a monitored setting. What about you guys?
Same experience. So now that we have, well-established programs and you have weekly labs, you see patients where you don't get to the stage where you are ANC less than 1500, right?
Yeah.
You see a patient where you can see the weekly trend. It's going down, and then by week 3, it's going to eventually reach there. So in that patient, if you stop the antimicrobial, I tend to do the same thing as you, not to list it as an allergy. And some of these patients in the future will get exposed again to the agent. So I think it is a duration issue more than anything else.
Yeah, neutropenia, I think it comes in different flavors. So then you have that's compared to a patient who like drops really quickly, and you call them and they say they do not feel well. Like they feel almost like they have the flu, and you're just crossing your fingers that they don't develop a fever. I feel like those patients are a bit different than these patients on prolonged antibiotics. I would list that in their allergy list, but that can be the hard part of these antibiotic allergies, is when they're not really cut and dry. Yeah.
Dave, I did have a quick question for you. So when daptomycin was first introduced, standard dosing was 4 milligrams per kilogram for soft tissue and 6 milligrams per kilogram for bloodstream. I don't think we use those doses anymore. I think we're using much, much, much higher doses. Are we seeing more eosinophilic pneumonia at the higher doses?
Yeah, that's a good question. I don't know if we have data to compare what the rates look like before, when we were initially using those doses, to what they look like now with using primarily 6 to 10 mg per kg. But that's a great question.
Thank you so much. Does anybody else have any comments or questions?
I have a question about thrombocytopenia, if you guys have a minute, or unrelated, but with especially here, I get kickback from people starting Zosyn with people with thrombocytopenia, like 50, 100, things like that. And I've done a lot of looking into it. It looks like it's mostly drug-induced thrombocytopenia after 10 to 14 days. I was just wondering if you guys have seen that more, and because to me, that's more of a true allergy, obviously a true allergy that you have to stop and list it. But I was curious if you guys started it at the lower levels and just monitor.
Thrombocytopenia for Zosyn, was that the question? I can't say on OPAT I've noticed that as one of the side effects that I've seen much with Zosyn, especially. Sometimes I'll monitoring these labs week by week. I feel like it's easy to contribute it to the antibiotic because that's what I have the control over. Although sometimes, especially cytopenias, I think we mistakenly do that, when in reality it's more infection related. So, you have this chronic sacral decube and you're anemic. Is it really cefepime or ceftriaxone, or is it because your body is in this hyper state of trying to control this infection? But Jacob, I haven't seen that too much. I don't know, if Dr. Sori or Jessica, have you guys seen a lot of that with Susan? Yeah.
I haven't either. Thrombocytopenia, I think, is slightly different than the, steadily decreasing ANC coming down. Thrombocytopenia tends to be a little bit more of that abrupt change, and I think I would consider that a true allergy for most of these antibiotics. As an institution, I think we use a lot less Zosyn than some of the other antibiotics. So that may be one reason why we don't see it as much.
Okay, thanks. Yeah, because a lot of the ICU docs and other ID people here don't like to use those initially. So more of an initial thing too, but obviously for the longer term, it makes sense for the quick drop.
Thank you for that question, Jacob. All right, we about have a minute. Does anybody else have anything before final announcements? Thank you, and thank you again, David, and thank you everyone for attending today. The next time we'll meet will be April 9th with Mira Metra discussing bone and joint infections. All right, thank you so much, everyone. Have a great evening.